Great, thank you. Could you, each person, if they could introduce themselves, please?
Hello, thank you for this session. Thank you for a great start. My name is Louise Bauer. I'm from the University of Sydney. I'm a paediatrician and I work in both clinical care of people with obesity, but also prevention of obesity. Jeffrey and any other members of the panel, one of the great issues that we're seeing is the rise of a number of non-communicable diseases, diabetes and obesity being great examples of those. And I'm wondering, in the healthcare system, how can we avoid people becoming patients in the first place? It seems to me that wonderful summary of information you gave actually is talking about once people actually largely start to encounter the health system. But how do we stop them encountering the health system in the first place, which is where so much is coming in? How can we stop that process?
Louise, as you spend most of your time in that area, what's your view about that?
Is a complex issue. And the on-ramps, interesting, some work that we're doing using Bayesian network analysis, but it won't be surprising to people. For childhood obesity, family poverty, parental education are major on-ramps to the development of obesity in adolescence. So you won't be surprised when I'm saying that these issues lie outside the health system, most of them. So they deal with issues to do with poverty, but also around how our food system's organised, our broader built environment system, issues to do with equity. And these are really important for the Academy to consider. And what we have here is really important. Once the person encounters the health system, we need to make sure that's fit for purpose and is shifted to the left. But I suppose I'm saying, how can we even shift some of our focus even further left? And I'd love to hear from some of the group.
Louise, can I comment? Because I think what you've said is not just a reason why it's important to consider that, but it's actually existential for the health system to consider that. Something quite remarkable happened around 2014, and that was the average life expectancy, a common measure of progress and health system performance, started going backwards in the United States. This was despite increasing expenditure. And it wasn't just in the US. The same plateauing has been seen in the UK and Germany. And while it hasn't happened here in Australia yet, it almost certainly will, for the reasons particularly that you've outlined. And it seems the extraordinary gains in life expectancy that were made in the 20th century, effectively doubling it in the last 100 years, are over. And yet the costs continue to climb, a whopping $4.1 billion, or 20% of GDP in 2020 in the US. And in the OECD countries, including Australia, increases of a similar magnitude from 9 to 12% over the last 20 years, and predicted to rise at 4% a year for the next 40 years. That's a staggering $24 trillion on healthcare across the world by 2040. Now, if you think of value in a healthcare system as being a simple equation of the cost of healthcare being delivered, divided into the benefit you get from the service, you could say it seems like the value of healthcare is not just on the decline, but might actually be going backwards. And it's a single reason why Jeffrey's question about excellent healthcare system by 2030 cannot be achieved by continuing what we're doing in 2022.
So I also agree, wanted to follow up with Louise's question. I mean, when we look at evidence, we get very excited about clinical guidelines and stuff like that. But let's take a step back. Australia's #1 killer is cardiovascular disease. What do we need to do? The global burden of disease that looked at the Australian data showed that if we just simply treated blood pressure and cholesterol, we could probably get rid of about 50% of cardiovascular disease. So Shane Warne dropped dead, although middle-aged men in affluent places have raced off to get exercise tests. So we spend more and more on the worried well. And I'm not suggesting it's easy, but if we stopped a whole lot of things we do, if we treated blood pressure and cholesterol in low SES people, we would probably do much better than anything else we do. And so, hand it over to you guys.
I'll just say something. I don't know where the thing is. I think you talked about complexity, but actually the complexities, I think we keep thinking about the health system as a bounded system, which links to so many other systems. And that's where the levers are for fundamentally shifting. I mean, we're talking about treating blood pressure in people who are poor. What about dealing with poverty? I mean, I think when I read the preventative health strategy, I kind of get all excited at the start. It talks about health inequality, even talks about people with disability for the first time ever in those kind of things, and then it forgets about it. It goes back to talking about basic risk factor, dealing with basic risk factors again, and the health system. So I just feel like we're still, until we talk outside of the health system, we're not going to fundamentally shift the health of the population. You talked about these deaths of despair. They're not going to be fixed by the health system. They're going to be fixed by fundamental shifts in our social policies. And so I really feel like we really need to start to think about the complexity of this system way beyond the health system. I could go on about disability, but that's another thing.
I think James wanted to make a comment. Thanks.
Yeah, thanks very much. If I can talk from a First Nations standpoint and perspective, the issue for us, I think, is, social determinants continue to be ignored, and not enough focus is on our people. Food security and food prices for most of our population is astronomical, particularly in remote areas, and that impacts totally from early childhood all the way through to adulthood. I think the clinical guidelines, I think our Aboriginal medical services do very well in adhering to clinical guidelines, and big improvements have been made around blood pressure and cholesterol and identifying those most at risk. All of us that are Aboriginal see our people die far too early in our population, and not enough focus is put on preventative healthcare and or social determinants of health. For me, I'm a researcher. We often are put into places where we are doing healthcare interventions, which is just one small part of the picture. I've always said if we could do a randomised trial of fully serviced remote Aboriginal communities versus standard Aboriginal remote community, we'd see much better results than all the trials that are done in ear health or rheumatic heart disease or STIs that I do. Fully serviced, fully adequate housing, employment, income for our population, we'd be a much better off population. Steve oversaw the introduction of synergy grants in the NHMRC. I'm a researcher, and synergy allows you to put a lot of multidisciplinary research into one project to address a single question, and that's exactly what we require, all the way from preventative to the best clinical care for our population. And very pleasing for me to see equitable healthcare system, because I think that's what we don't have at the moment. And equity is not just about us having access to the same hospitals and healthcare as everyone else. We've got hospitals and healthcare. We're not actually in those hospitals as much as everyone else. Equity for me means, having access to instead of implementing new technology and scientific advances and the technology and digital into the mainstream population, put it into Aboriginal population, because that's where the greatest gains can be made first, and then put it into mainstream, because what we see is the non-Aboriginal population continuing to improve, and we're not closing the gap any further because we're staying stagnant. And so for me, I think equity is about putting the right interventions, the new interventions, first into those that are most marginalised in our population.
Thank you. Joanne.
Thanks very much. Might make a follow-up comment, because I actually think primary healthcare more broadly has a lot to learn from Aboriginal medical services, and in fact some of the things that they do in terms of team-based care and how they're managing to achieve a lot for the communities that they work in. But I was really happy to see, Jeffrey, that you talking in your presentation about the need to move things to the left. Working in the general practice space, we've got a major we've got a major problem. There's going to be a 38% increase for general practice services over the next 10 years, and there's going to be a 15% reduction in the GPs in cities to provide those services. So something clearly has to change. And you're right, we're sitting here together in this beautiful setting with lots of beautiful new hospital facilities and more to be built. But a lot of you might not have noticed as you walked in through the front door that you passed a general practice. Because they're small, they're invisible, they're in the community. And I agree that while we need all these population health issues, we need viable primary care settings so that people that are from all of these different population groups have a general practice to go to for their immunisation, for their preventative health screening, so that they aren't developing diabetes, or if they are, they're diagnosed early, and hopefully reducing the need for them to progress to need services next door, for example, at the Royal Melbourne Hospital. So I think that there needs to be a focus, of course, on population health, but there needs to be an increased focus on other models of care, other models of healthcare funding, and an increased focus not just on hospital care, which takes up a lot of the bandwidth, but what we're doing in the primary care setting. The primary care setting is not just about reducing ambulance ramping and hospital readmissions, it's about preventing the need for any of those things in the first place. And unless we move more of our efforts to the left, both in terms of research funding, but also healthcare funding, looking at how states can contribute and not just the federal system, then we're going to end up with some issues. The good thing about a crisis is that it focuses attention. Now it's what we do in this space of time to design something more fit for purpose in the future that is more equitable for everybody. That's our opportunity.
And following on from your comments, Joanne, just yesterday in the press was the mention that of all the people we're graduating in medical school, fewer and fewer are going into general practice. So we're producing, bus loads, aeroplane loads of doctors, but they're not going into general practice. So that's a system failure. These are people that are where the Australian taxpayer funds in a large part their education, yet we're shifting away from general practice. So surely that's a system-wide problem that needs to be addressed. We don't need a lot more highly specialised people. Well, maybe we do, but we need general... can you guys comment?
Just another quick set of numbers around that. About 9% of the adult population has diabetes, and almost as many people have impaired glucose tolerance. About 12% of healthcare expenditure is spent on diabetes. And the vast majority of that, almost 90%, is on treatment of complications of diabetes and serious complications of diabetes. Surely there's an opportunity to improve patient outcomes and to reduce expenditure by shifting to the left, as Jeffrey said, and as Joanne has advocated the need for.
Shifting to the left requires those services to be accessible, and they're still not accessible to vast portions of the population. One part of it is cost, but another part is all kinds of accessibility needs, from physical accessibility like ramps through to actually cultural competence of practitioners. And I think I'm just going to reflect on the group of people. My research on disability and just quote one statistic to you. People with intellectual disability die 27 years earlier than people without intellectual disability. 38% of those deaths, 38% of deaths are avoidable compared to 17% of deaths amongst people without intellectual disability. People with disabilities have been getting poor health care for a long time, including primary care, and COVID really, really showed that people didn't have the help, they didn't have the general practices to go to. So, it's all very well to say go and get antivirals. They didn't necessarily have a GP. The GPs aren't. There's no way of getting care to people in their homes or appropriately person-centred care. There's a huge proportion of the population who are just not getting appropriate primary care. So I just want to think when we talk about primary care, we really need to start to think about access of a large, 18% of the population are disabled, but there's a large proportion of those who can't actually get decent care, end up in the hospital system. Then we get all the complexities of interactions between the disability service sector and the hospital system.
Thank you. Are there So there's quite a few, thank you.
Hiscock, paediatrician, and this is music to my ears. I lead a CRE in childhood adversity and mental health, and we are integrating health and social care to better address the social determinants of mental health in families with 0 to 8-year-old kids, because you've got to start early. I have learned through this that care follows funding, and Medicare is not fit for purpose. And Joanne and I have had lots of conversations about this, but I'd love the panel's reflection on what should be our funding models going forward if we are to integrate with our social care and education colleagues and truly do integrated, equitable care.
Well, I don't have the full answer, Anne. I wish I did. But having said that, I think one of the things is voluntary patient registration. Until that happens, somebody can't necessarily name their GP, and a GP can't necessarily name who the patients are that that they and the team of people that they work with are responsible for caring for. I think that we need to look at innovative models to make sure that particular maybe more vulnerable groups or people from lower socioeconomic areas do have access. It is a problem, and if we're currently going to keep on relying on MBS, what we're seeing is closures of general practice because they cannot continue to provide purely bulk billed services, and that's going to increase the pressures more. So I think we need to look at block funding for general practice. I think that we need to look at different models of care where there is the traditional private general practice, but then there's potentially other models of general practice where we have salaried GPs who work in multidisciplinary teams that are, have a particular focus on making sure that some of the different kinds of people that we've talked about today can access a high quality service where they get the time that they need and a team that can address the complexities that are unique to that person's situation. So until we think about changing the funding model and getting states, plus or minus private health insurers maybe even, involved in providing some of these more innovative ways of funding so that we're creating services that are fit for the people that need them rather than continuing to try to keep on doing things the way that we always have.
Harriet, can I make a comment? What Joanne's just described is effectively a version of value-based healthcare where the fundamental driver change that needs to happen is stopping paying for services where there is no incentive to improve quality or to match it to patient outcomes, and to instead pay for value, and the value are outcomes that matter to patients. And in systems that have tried that, it puts patient priorities, their experience and their clinical outcomes at the centre. The patient becomes the centre of the journey, and everything that is done in the cycle of treatment for that patient can be weighed up against each other. It becomes a personalised medicine opportunity where the clinician doesn't have to follow guidelines that often are perverted by cost considerations, but actually tailor what's best treatment for the patient. And this is obviously a tricky thing for a federal government that as soon as they suggest that they might alter the MBS system away from fee-for-service payments, there is an outcry and phone calls direct to the minister. But it's a really important thing for us to think about, is how we shift from pay-for-service to pay-for-value.
So that's an interesting idea, and I'm not suggesting we shouldn't do it, but how do we then deal with the slow obesity epidemic, the exercise which we want people to do, the fact that people need their blood pressure and cholesterol, but because they haven't had a heart attack may not value that?
Well, the whole system would push to the left, I think, in that system, because that's less cost for higher quality outcomes for the patient to prevent rather than to do their obesity surgery or to do other high cost procedures.
Harriet also mentioned the social care sector, which we haven't mentioned, and I think that, we don't really call it social care as much in Australia as they do in the UK. But I do think that one of the challenges, and it really came out during COVID, is the real connect between health and social care services. And and actually once you start to talk, when you hit that, when you hit the departments, when you try and talk to DSS or you try and talk to the Department of Health, you know, and that's not disability, that's not health, it's this ridiculous conversation that, and they kind of know it's ridiculous, but it's still there, because there is a really important role of the social care sector in preventative health and in making, you know, oral health care, looking out for violence and abuse and neglect. You know, yet we really don't value that workforce. It's a really undervalued workforce, and it's a really high level of skill set, and it is a link into the health system, both a link and preventing you get into the health system. So I think we ignore how we can work with the social care sector to actually deliver better health outcomes. So I really appreciate you asking that question. I think that's where you were going. And I think one of my frustrations is because the two government departments I work most with are DSS and Department of Health. And so and in COVID, clearly we needed to engage disability services, but it's very complicated and very hard. So thanks for the question.
Can you hear me? Yeah. Hi, Fran Baum from the University of Adelaide. Jeffrey, I liked your conceptualisation of the system, but I think what you were describing was an illness care system, not a health system. And I think we need to start calling it that. But I also think that illness care system has a kind of stewardship responsibility for all those broader commercial and social determinants of health. And at the moment, I've got an ARC grant researching the history of community health services in Australia. And we've been reviewing health policies since the 70s. If we look at, under the Whitlam government, the Hospital and Health Services Commission, there is nothing in your left-hand column that report didn't deal with. So we're still repeating the issues that we were looking at in 1970, well, I think it reported in 1974. So I think we need to bear that in mind, that there are deep structural issues of power that keep the system as it is, that don't shift it, that go to the minister when they don't like the idea of doing away for fee for practice. And we will never get healthcare system reform unless we deal with that power. So that's the first one. The other thing is that I think health systems have this stewardship responsibility. WHO has conceived of this. We conceived of it in the Commission on the Social Determinants of Health. So to advocate for issues. At the moment, what would you advocate in Australia if you wanted to reduce health equities? I suspect everyone in this room will benefit from the stage 3 tax cuts. There may be a few who don't, but most would. Wouldn't it be great if this Academy can say to the Prime Minister, let's do away with those stage 3 tax cuts? And let's put them into a particularly important NDIS or an Aboriginal health project to strengthen the community-controlled health services, which is probably the best model of care that we have in Australia. So just some things to think about, those deep structural issues which are driving inequities, because it isn't the illness care system, it's all those other things that happen.
Sure. Thanks, Fran and Harriet, and of course you've thought about this as much as anybody on the panel. So my brief was to talk about the health system, but yes, absolutely, the starting point is society and the social determinants of health, which is what we've sort of now started to talk about. But I wonder, as you were talking and as I was listening to the panel, have we got an appetite for a big bang approach to reform? You always think when a new federal government comes along, maybe that's an opportunity, but I'm not sure yet. Because what this is, the class of problem this is, it's the fixing the plane while flying problem. We're trying to fix the plane and maybe move it from a Havilland Hawker 1947 version to an A380 while we're flying it. So how do we do that is the real problem that we've been grappling with a lot. And I know people in this audience have. How do we, what starting point do we take and how do we reform all the things that I've talked about and you've talked about, Harriet and Fran? Because that's a really big class of problem. If we do it incrementally, we'll get whatever we get by 2030. If we have a big bang, that's awfully scary, and there's a lot of stakeholders who are vested in the current system. And I won't mention names.
So I'll just follow on with my comment before that it'll be the states and territories and the community-controlled sector that has to lead on this because of the risks for the federal government in changing the MBS without really good reason to and wholesale community support to do so. And so there is a need and there's a role for pilot projects that demonstrate what fund holding and bundled payments can do and to show absolutely conclusively, as has been shown in other places in the world, that that system of incentive payments going in the right direction, using the ability to tailor them to the best outcomes of every individual patient, giving the providers the autonomy to make those decisions, but making sure they work in networks as groups that include social services where relevant, where shift care upstream where relevant, is actually the way to change the system. And that would give confidence to the federal government to be able to change a policy around financing of their healthcare.
You might need to just...
I just wanted to give a plug for some of the remote Aboriginal communities where the Aboriginal organisations are already integrating healthcare with other systems. So, for example, in Fitzroy Crossing, healthcare is delivered in the preschool and the childcare, and it's linked with the legal aid service and the domestic violence service and the parenting programs, etc. So it can be done, and I think those organisations have very short-term funding, and we've absolutely got to support them, enable that continuity of care that we talk about, Jeffrey. Yes. The sustainability of the system.
Can we, just to the organisers, can we make sure we get a mic to people, because otherwise your question or comment may not be captured for posterity?
The mic has gone left. Hopefully it will stay left. So
That's actually right.
Yeah.
Not left.
My point depends on the perspective. So
Exactly.
John Saville, I'm a retired clinician scientist and I'm looking after the local research translation centre. Jeffrey, it was a fantastic talk. I really enjoyed it. I like numbers. I'm a nephrologist. I like 60, 30, 10. You know, that's an easy concept. But I wondered whether the 30 and the 10 were an inevitable consequence of getting the 60. Let me just explain. So I spent much of my life talking to patients about going on to dialysis acutely or chronically. They would always say, what happens if I don't do that? And I'd say, you will die in hours, days, or weeks. So the alternative to the harmful 10% of episodes that I am responsible for is death. The alternative to the 30% of wasteful episodes that I'm responsible for is death. I'm sure I created lots of harm doing dialysis. I know I created lots of waste because you could not tell if a 95-year-old would benefit from dialysis until you'd started it. So are waste and harm an inevitable consequence of effective care? And what's your target? I always had a target, my hemoglobin, my potassium, my phosphate. I knew where I wanted my patient to be. What's your target, Jeffrey? 60, 30, 10. Where should it be?
I don't have a target, John. All that models, and it's a simplification of reality, as you've just pointed out, that model. All that model says is, if we had better numbers than that, we would have a better health system. That was my brief to talk about the health system. I don't know what the system could deliver, but there is the complexities that you are mentioning about what constitutes waste and harm, and what are the alternatives to not doing something for someone. So, I mean, you're absolutely right. We should write a paper on it.
But interestingly, one of the sort of hot ticket items at the moment is joint replacement and the waiting list for joint replacements, and everybody scurrying around trying to work out how we're going to deal with the waiting list. Of people that have a completely technically fantastic knee replacement, 30% are dissatisfied with the result. that is waste. So I think the stuff Jeffrey spoke about was, clear, fairly clear cut. But we've got 20 to 30% of people where we're spending a lot of money. They're going off and having this surgery. You could argue that if we spend some time trying to work out which groups they are, we could divert funds. Anyway, I'm just raising, and I'm sure people in the audience have a lot more examples. Thank you.
Thank you. Mary Galea, I'm from the University of Melbourne. My background is physiotherapy. I think we've been talking a lot in the health system about the key indicators of health, which are mortality and morbidity. And I'd like to suggest, as the WHO has suggested recently, that we have a third indicator, which is that of function. And I think this would go a long way to having us understand better not just the numbers of high blood pressure or obesity or anything like that, but how people function in the community, what their activity limitations actually are, what their participation restrictions are, which then link to the social issues that we've just discussed. And I think that accepting such a third indicator would be very helpful in evaluating outcomes for the health system in the future.
Yeah.
I think that functioning is one important indicator. It's interesting, I think, when the NDIS was meant to be organised around functioning as the assessment criteria to get into the NDIS, which disability community was right behind, because that's actually, functioning is why you need support. But again, the NDIS went down a completely different way, down diagnoses, and has forgot functioning, I think, and really, really problematically, because we can't actually, and it also can't measure the impact of a lot of the services that the NDIS is giving on functioning. So I do think functioning is one potential measure. I mean, so if you're talking, I'm presuming you're talking about the international classification of functioning. Disability and health. But the other indicator, aren't they also considering putting a wellbeing indicator in the next budget? And I actually would really be behind that. I don't know whether people know more about that than me, but I know that that's a proposal of the current government, that wellbeing will be a new indicator.
There's some jurisdictions that are using wellbeing already. New Zealand championed it. Through some work with Deloitte they did, and the ACT has actually picked it up and been surveying the population and recording wellbeing. It's on the ACT government website.
Because I think you've got to, people may not have high functioning, but they still may have high wellbeing, and we should still be aiming for high wellbeing. So I think there is a problem still with functioning, seeing as a kind of almost like. My problem with public health is that often people with disabilities aren't seen as having health. If you look at the WHO definition of health, it says the absence of disease and infirmity, or I can't remember the whole thing. It's almost as if you can't have health if you're disabled or if you have a lower functioning. Whereas wellbeing is a different kind of aspiration. And I think there's a problem with functioning still as a kind of something that we aspire to.
Mary, as a trauma surgeon, I've seen a shift over the last 15, 20 years, led by people like Belinda Gabay and Peter Cameron, from mortality as the outcome at the end of trials to 6-month outcome measures of function. And then now we've got 12 and 24 and 48 and 5-year outcomes in the Victorian State Trauma Registry. So there are genuine scientific attempts to try and shift from just dead or alive to proper measures of function and disability. And we're seeing some surprising outcomes in the trials, where you've got a good outcome at the end of 28 days in hospital discharge, and it's the opposite at 6 months' time down the track. Those things are really interesting to unpack.
Yeah.
Functioning well-being are important and stretch across the whole population. I'm thinking of geriatric oncology, what predicts the best outcome, there. Function is a key one,
Yeah, and Fran would know this better than most of us, but there's a whole movement now about, instead of constantly focusing on economics, gross domestic product, shouldn't we be thinking about gross domestic well-being? you know, and that takes you all sorts of places. Anyway.
James? Okay, good. There's a question on the online, and that's how do we as members of the Academy address inequity and increasing wealth gaps and its effect on health?
I always refer those questions to the president of the Academy personally, but...
Well, Fran made a suggestion that we donate our tax cuts, which are ridiculous.
We can also make a statement.
Yeah. I think we're preaching to the converted, aren't we? Sort of. So any comments?
Hi everyone, I'm Ainsley Newson. I'm a bioethics academic at the University of Sydney. I'm also a mentee and associate member of the Academy, and we had a fantastic workshop yesterday. And so if you know anyone who would be considering becoming a mentee, please encourage them to do so. It's a brilliant program. I was going to kind of make a suggestion really about the rules of engagement going forward. So as a bioethics scholar, something that's really integral in our discipline is to start with conceptual clarification. So to look at a term, to unpack it, to critically analyse who's saying what about it, are they right, you know, what are the implicit things behind their terms? And I think it's highly relevant here when we think about terms like harm, value, well-being. All of these things have different connotations and definitions, potentially depending on your disciplinary background and the baggage or methods and knowledge and data that you bring with you from that. But I think we haven't yet genuinely started to have a conversation across those boundaries about when I say the word value, I might mean something quite different to when a health economist says it, for example. And I think to try and fix some of these really big problems that we've been talking about and to try and implement some of the excellent suggestions that have come up, we need to also be clear about what we're talking about and to be clear about that when we're using those terms. Just a comment, really, unless anyone violently disagrees.
Except you made the job harder, Ainsley. Yeah.
Can I ask the panel to each answer a pull together question as we come to the close? What is a practical step that could be taken, say, tomorrow to begin the delivery of an effective, scalable and sustainable initiatives? So it would be, you're from different aspects of the issue. It would be great to get your views.
To start making more of a sustainable health system.
Does anybody...
So I'll go back to what I said before, was I think we need pilot projects that pool funds that centred around a particular condition that's got fairly clear, agreed processes of care right through from prevention through to management of advanced disease. And we get the relevant stakeholders together, the relevant jurisdictions, and we agree to come up with a pilot project that brings funds into that. That might be billings, that might be some additional funds on top of that. Distributes those according to what we think as a group best practice would be, and it makes sure that we include in that social services, we include home-based services, we include primary care at the centre and the patient at the centre.
So, Jeffrey?
I just run off that and what I said. Two things really. One is we haven't really agreed what we would like to see in terms of society, social determinants, the health system by 2030. We haven't really agreed on that. We sort of skirt around it and you get a report, from somebody or government or Deloitte or somebody in a jurisdiction. We haven't really brokered that to say what would we like and then get the arrows going in the right direction. The second thing I'd say is how important the Academy could be as a voice for articulating the things we're discussing. And that's kind of exciting because we're getting together now. We're face to face. So, we have a voice, an evidence-based perspective that's very important, that hasn't been heard before the Academy existed.
James?
For me, equity, moving everything to the left I think is important. I'm reminded of a talk that Dr. Noel Heyman gave this week to our group. And really, it's not rocket science. He runs a Indigenous primary care service. It's a mainstream service in Inala, a large Aboriginal population there. All the specialists come to the Inala clinic now, and the patients are not expected to go to the hospital. An amazing turnaround of attendance, of not showing up in the hospital. Every single cardiologist there, ophthalmologist, everyone's there. Really amazing, just a simple intervention that has worked incredible outcomes for the population in Inala. So sometimes I think we overthink the system, so sometimes the answers are right in front of us. And for me, there's a few other things. The optimisation of workforce, and COVID really showed our community the vulnerabilities in the workforce in our populations. When communities were cut off, there was no third workforce. We rely on two workforces, a fly in, fly out one. So no third workforce. Our population clinics were closed. And that was really problematic. And I think without a very decent inquiry into the health workforce, I think we're in big trouble into the future. And the digitisation in our setting. I think there's a digital divide between Aboriginal and non-Aboriginal people in Australia, and the optimisation of digital models of care, trying to understand how we can link the interoperability of systems between hospitals and primary care, for instance. Huge task. It seems simple, but a huge task, and laden with a whole lot of issues around data sovereignty and privacy and a whole lot of other issues that need to be worked through. But we're starting to get some inroads with that, particularly in the maternal and child's healthcare space. So really important things, I think, that that need to be fixed up for our population as we go forward.
Joanne?
There's so much there. The beauty of the Inala model is that it occurs in Inala, which is a community health service staffed by GPs who see all those patients and then only consult the endocrinologist or the cardiologist in a case conference when required. Showed way less fail to attends, health economics proven, and equivalent outcomes to a hospital outpatient clinic. So there's so much stuff we know. This is about the translational issue, about taking it so it's just not in Inala, but broadening the issue. To be able to do that, there's a couple of things also that are required. One is, but many of the people here, including myself, work at medical schools. The culture has to change so that primary care, preventative strategies, early intervention, working, with all of those other kind of important people that influence population health is valued. And so people want to become GPs or nurses in primary care or whatever the case may be. Until we shift that culture, we're going to have ongoing problems. As an academy, I'll just say anything that you can do to advocate for increased research funding for the primary care space, particularly in health services, that as a mandatory part needs to include people from primary care and people that attend primary care for their care, is really, really important. We're grossly underfunded in the research, which means we can't prove models of care like Inala work, so that we can get that translation happening. So if we can change the culture, move some of that funding to the area that we know really does need it, then we're going to have a lot more impetus to be able to make some of these other broader changes as well.
And Anne?
I really don't even know where to start with. So I just want to say one thing. People think that disability is sorted because of the NDIS, and I just want to remind that makes up 12% of the disabled population. So one, it doesn't provide health services and doesn't do a whole lot of other things. So that's an issue. I think part of the problem is this issue of whose responsibility is it for the health of people with disabilities. And so I hate to have more reports, I really do. But I do think there needs to be some sort of combined disability and health strategy. We now have a disability and health sector committee, so we're actually talking to each other now. But we need to, so that we can understand where the various levers are, both outside of the health sector and within the health sector, to improve the health of people with disabilities. So I think that really is quite urgent, and there needs to be some responsibilities around that, because I think the health department would really quite like to wash its hands of the issues around the health of people with disabilities, and it just can't. Instead, it does these things like it's got a strategy. It's great. It's got a strategy for people with intellectual disabilities. It's going to create one for people with autism. So we're going to have two strategies based on advocacy from people from those groups. It's not appropriate. We need a whole approach for people with disabilities. I'm not going to take away those things. I've been part of those discussions, but that's a medical way of coming at the problem. So we need to really think really carefully about how we can work together across those systems. And I think fund holding models are really one way of thinking about getting better primary care for people with disabilities, which is appalling at the moment. That may well be one group in which some of these trials are actually are thought about. So I think that's an opportunity for people.
Thank you very much. I know there's lots more questions and comments and stuff, but I think we've got 2 days of the meeting, hopefully, to share some of these ideas. I think the whole notion of what the academy can contribute, we should have at the back of our minds. I mean, it'd be disappointing to find that we come back or we won't, but someone else comes back in 30 years or 40 years, we discuss the same things over and over again. But I would like you to thank our panel and Jeffrey, who was in for his talk, and it's morning tea. Thank you.